I'm Pam Kunz. I'm a medical oncologist at Yale School of Medicine and Yale Cancer Center, and it's a pleasure to speak to you today on navigating treatment sequencing. These are my disclosures. So today I'm going to talk about treatment sequencing, how we make decisions as a team. We'll talk a little bit about the differences between neuroendocrine tumors and neuroendocrine carcinomas in terms of treatment sequencing, and then discuss what this means for you. So I like to start with this timeline just to really share how far we have come in terms of treatment advances for patients with neuroendocrine neoplasms since the 1980s. We've just had an explosion of research demonstrating kind of above the timeline advances in imaging and below the timeline advances in treatments. This has made treatment decisions in terms of how we think about sequencing treatments very complicated. And there's so many treatments, and it is objectively very confusing. And so we want to try to help provide some clarity around that for you. So what is treatment sequencing? We really think of it as the right treatment at the right time, with the understanding that plans can change over time and that there are multiple treatments that you may need over time. And so for patients of mine that are listening, they know that I use the toolbox analogy. So I'll describe that for all of you. So let's say we have an empty toolbox. So we start with number 1. We then have several tools that we can use at number 2. And we want to try to add those tools to the toolbox. We tailor that for patients. So one patient may start with the pliers and then get the screwdriver and then get the hammer. And then another patient may get those tools or treatments in a completely different order. So what I'd like to talk about next is how we think about making these treatment decisions. What guides us? So I use these 8 separate variables to think about doing that. So functional status, meaning whether or not your cancer secretes a hormone. Where did the cancer start? That's the primary site. Stage, volume of disease, degree of differentiation and grade are both features from the pathology. Somatostatin receptor status, and then your goals are a very important part of this treatment decision. Optimal care really requires expertise and multidisciplinary coordination. So in terms of neuroendocrine tumors, the goals are to control growth, reduce symptoms, maintain quality of life, and ideally prolong survival. And for neuroendocrine tumors, starting treatments in the oncology lingo, we call that first-line treatment. We can think about using somatostatin analogs like lanreotide or octreotide. Dr. Pegna will be talking about that, or has already. And surgery, Dr. Halle already discussed that. And then watchful waiting. And watchful waiting would mean if a patient is asymptomatic, maybe newly diagnosed, we may think about watching with serial imaging before even starting treatment. And there are select patients for whom that's appropriate. If the tumor grows, and in oncology lingo, we call that the second line or beyond treatments, we think about radioligand therapies, targeted therapies, chemotherapy, and liver-directed therapy. And Dr. Chan spoke about radioligand and targeted therapies, and Dr. Sulin talked about liver-directed therapies. So systemic treatments for patients with advanced disease fall into 4 main categories. You've heard several talks on these already, but just to kind of bucket them for you. So somatostatin analogs, we said, could be used often in the first-line setting. Then radioligand therapies is another bucket. Targeted therapies include everolimus, sunitinib, and cabozantinib. And then cytotoxic chemotherapies include both IV and oral chemotherapies like streptozocin, Cape-Tem, Cape-Ox, and Fulfox. So the next step, we have all of these different treatments. So in those 8 factors that help us make those treatment decisions, the goals of treatment include stabilization and response, i.e. shrinkage. And then we think about the side effects. Are the side effects pretty minimal, or does a treatment have more side effects? And so as we think about those 4 buckets of systemic treatments, and as I'm talking with patients and thinking about how to tailor those treatments, we also will discuss, well, somatostatin analogs, in general will yield stability, and they're very well tolerated. So it is for patients that maybe don't need shrinkage of their tumor, but stability would still be considered a win. If a patient needs shrinkage, we then think about going to radioligand therapy or cytotoxic chemotherapy, but those are going to have more side effects. So you can see it's this really tricky balancing act. I want to just talk to you about how oncologists, whether it's a NET expert or your community oncologist, makes these decisions. So the NCCN Neuroendocrine Tumor Guidelines, that's the National Comprehensive Cancer Network, has guidelines for physicians. There are neuroendocrine tumor patient guidelines that are really wonderful. So there are algorithms in terms of how to use these systemic treatments. We are starting to get more data around the lines of treatment. But at present in 2026, we have all these tools for that toolbox. And really, the way that we primarily determine sequence is based on those 8 factors of primary site and patient goals and grade, et cetera. What's really exciting is that several recent clinical trials have either evaluated sequence or some new ones are starting to do that. So in the early days of clinical trials for NETs, we generally compared a treatment to a placebo, but most of our recent trials are comparing active drug to active drug, and that is helping us to teach us if one treatment is better than another. So the top 4 trials, NETTER-1, NETTER-2, COMPETE, and OCLA-RANDOM, all compared an active treatment versus radioligand therapy. In all 4 of those trials that are now complete, the radioligand therapy did better. These were in various lines of treatment. I think importantly in COMPETE and OCLA-RANDOM, we know that ludotatate or luetitriotide did better than everolimus and sunitinib. So the way I use that information is I typically use everolimus and sunitinib a little bit later in a patient's treatment course. Sadly, the COMPARE-NET trial actually closed early due to low accrual. This was a national clinical trial network trial, which is conducted through the federal government. And sadly, we couldn't get enough patients. And so this is a very practical trial. And I get asked for patients with pancreatic NETs, should we use CAPE-TEM or ludotatate? And this would have been a way to answer that. And sadly, we may not formally have a trial that gets at that answer. This slide talks about NEC or neuroendocrine carcinoma and how it's different. So for neuroendocrine carcinomas, how is that different? Well, they tend to be faster growing. We often need to start treatment more urgently. And the treatment is a lot like small cell lung cancer. And actually, many of the principles are based on how we treat small cell lung cancer. And we often extrapolate. And so we're starting to get more trials that are based on some trials from small cell lung cancer. So the NEC systemic treatments fall into 2 main buckets. The first line or starting treatment is usually cytotoxic chemotherapy with platinum etoposide. There are some other chemotherapy combinations. The acronyms are FOLFIRINOX and FOLFOX. And then immunotherapy has been studied in some small trials, including immunotherapies like pembrolizumab, ipilimumab, and nivolumab combined. We have some ongoing clinical trials in these extrapulmonary neuroendocrine carcinomas looking at immunotherapies. So we'll have to stay tuned on that. So this is an excerpt or an adapted version of the NCCN guidelines again for GEP-NEC systemic treatments in 2026. So I've listed several other types of chemotherapies, but the carboplatin etoposide or cisplatin etoposide is really considered a first line or starting treatment. But then we have several others that we can fall back on in the second line and beyond, including immunotherapy. Occasionally we will use local regional therapy options such as radiation. But again, that's very patient specific. I didn't mention when we talked about NETs, but clinical trials are always part of this conversation. And if we think back to that toolbox analogy, when I am talking with patients about a new treatment or a change of treatments, we'll always talk about standard of care options and clinical trial options. So what does this mean for you? I think that there's no single right order. And another way to think about it is that there are several options for you. Plans may need to adapt over time. We really encourage you to ask questions about why we're making the decisions we're making. And again, you have options. So let's put our knowledge to practice. So I'll remind everybody, these are the 8 key variables that help us make treatment decisions in terms of sequencing: functional status, primary site, stage, volume of disease, differentiation and grade, somatostatin receptor status, and your goals. So we're going to do 2 cases together. So this is a 60-year-old woman. She has a newly diagnosed metastatic, non-functional, well-differentiated grade 1 NET of the small bowel. The Ki-67 is very low, it's 2%. And she has low volume liver metastases, generally meaning that they're small. This was in fact found incidentally at the time of a hysterectomy. And so she was completely asymptomatic. Her small bowel primary tumor was surgically removed. And then we're thinking about, well, what's the best first line or starting treatment for her? So the top is a picture of her abdomen. It's an MRI. It is a cross-sectional image. So think of it like a bread slice through your body. And this just captures a portion of the liver. The liver is on sort of screen left, but it's sort of physically and anatomically on your right. You can see some small darker spots in the liver. One of them is measured. You can see that there. It's 16 millimeters. Another way of looking at this is with the gallium-68 dotatate PET CT. And this shows some of those dark spots in the liver. Those represent the neuroendocrine spots. So again, best first-line treatment options include observation, a somatostatin analog, fludotate, capecitabine temozolomide, or liver-directed treatment. And so as you're thinking about that, I'll tell you the correct answer. And there's actually probably 2 correct answers here. So one would be observation, and a second would be a somatostatin analog. That decision, I think of as shared decision-making with the patient. It is very difficult to tell a patient that you have a newly diagnosed cancer and we're not going to treat you with anything. But if I then go deeper into the rationale, the clinical trial actually proved and showed that octreotide and lanreotide worked. The patients who got placebo had several months, in fact, up to a year and a half on the lanreotide trial before they had any progression. So for select patients, watchful waiting with serial imaging may make some sense. But if a patient is very worried about not starting on something, that's exactly when we have that conversation. And that would be consistent with a patient's goals, perhaps to start a somatostatin analog. Okay, one more case. So this is a 60-year-old woman with a 2-month history of abdominal pain, GI upset, low appetite, and 10-pound weight loss. So note immediately that she is symptomatic compared to our last patient. The MRI showed a hypervascular pancreas mass and large liver lesions. A liver biopsy showed a well-differentiated grade 1, Ki-67 2% net. These are both MRIs. So in the upper panel, you can see a large liver lesion that's up to 58 millimeters or close to 6 centimeters, sort of the size of an orange. On the bottom panel, towards the right, there's a 23 millimeter pancreas mass that's over along the right side. So same question, what's the best first treatment for her? Somatostatin analog, lutetium dotatate, capecitabine temozolomide, cabozantinib, or liver-directed treatment. So as you're thinking about what we learned today, we really need something that has the potential of shrinking the cancer because of how symptomatic she is. The 2 main options include lutetium dotatate and capecitabine temozolomide. So sadly, we won't have that trial that was comparing those to answer that question. Again, I will talk with patients about what side effects can be expected with both treatments. Patients will often get both of these in their lifetime. So really, it's just a matter of tailoring and thinking about both logistics of treatments and side effects that help us make that decision. But both are correct answers. So just to wrap up, treatment is a journey and plans evolve over time. You have multiple right options. Clinical trials are an important part of that and really a wonderful way to continue adding tools to the toolbox. So as you are exploring new treatment options, whether it's a first treatment or whether it's a second or third treatment, please be sure you're asking your treating team if there are clinical trials for you. The right treatment depends on your tumor and your goals. You are a critical part of this decision-making. We really encourage people to ask questions and be part of that shared decision-making. And the goal is to both control the cancer and help you maintain excellent quality of life while we do it. So thanks for the opportunity to talk to you today about sequencing. It's a tricky area. I'm happy to try to answer questions later. Thank you.